I just wanted to thank you all for joining us this evening for the third in our RT UK Talks series. So far these talks have been aimed at radiotherapy professionals, but I'm so pleased to say that tonight's talk is for both patients and professionals, so a huge welcome to you all. My name is Sarah and I am the Director of Radiotherapy UK, the only charity in the country advocating specifically for this life-saving yet underfunded treatment. And we do have our work cut out for us, as radiotherapy in the UK receives 5% of the cancer treatment budget, while many countries spend closer to 12%. We're here to represent professionals and the patients and to create change at a political level through our award-winning Catch Up with Cancer campaign. I'm joined tonight by Alison and Lindsay from the team who will help run the session. Lindsay worked as a therapeutic radiographer for many years and will also be helping out with the questions section later this evening. And tonight's guest speaker is Naman Julka Anderson, a truly incredible advocate for the radiotherapy community. Not only was he named UK Radiographer of the Year by the Society of Radiographers in 2022, but he has founded one of the leading oncology podcasts, RadChat, and is a valued member of Macmillan's treatment review team. He's been in the newspapers this week campaigning against inhumane waiting times for cancer patients, and we are honoured to say that Naman is an active member of our Champions Network and is captaining RadChat's Miles for Radiotherapy 2023 team this year. He has a really fascinating talk for us this evening that features some excellent insights into equity, diversity and inclusion for cancer patients, how you can become an ally and how you can upgrade from assessment techniques like the Fitzpatrick scale and classify skin tones with more accuracy and inclusion. So just before I hand over to Naman, a little bit of relevant housekeeping. Please do use the chat function to introduce yourself and for any comments and questions throughout the presentation. This is such a good opportunity to engage with each other and with Naman. And we're just going to do a quick poll right now to gauge where you are with this particular subject. That should be up now, and I'll just give you a moment to answer the question. Again, this type of feedback is really helpful for us. It's great, lots of responses coming through. That's fantastic. So after Naman's presentation, we do have time set aside for a Q&A session where we will get to as many questions as we can. On our previous webinars, this has been really engaging. So please do take this opportunity to put in your questions and we can have a conversation. And we'll gather them throughout. So if something pops into your mind as Naman was talking about it, feel free to put it in and we'll be gathering them throughout to put to him at the end. We will send out a follow-up email following this webinar with the recording and any other relevant links that are discussed or highlighted throughout. So without any further delay, please welcome Naman Julka Anderson.
Thanks, Sarah. I'll just quickly share my screen. Thank you for a very kind introduction. Is this the wrong screen? Is that better?
Yeah, that's it.
So yeah, hi everyone. Thanks for giving up your Thursday evening. So if you don't know me, as Sarah's very kindly introduced me anyway, I was born and raised in India, moved here in 1999, and then I worked in a lab looking at poo, bone marrow, blood, all sorts of different samples before deciding I really didn't enjoy it. And then I moved into radiotherapy through a master's route. So I now work at an advanced practice level within treatment review. So face-to-face reviews or virtual reviews of patients for psychosocial problems. I'm also very fortunate to now work permanently 2 days a week for Macmillan Cancer Support within the Chief Exec's office. It's a very long title, which I always get wrong. It's a National AHP Clinical Advisor for Macmillan Cancer Support. So doing lots of different projects for the UK, basically, which is great. And there's a few charities at the bottom that I'm quite lucky to be working with. And one half of my face is fortunately on the logo as well for a podcast. So a few little bits and pieces I'm going to talk about today. So EDI, or quality, diversity and inclusion. I've got a quiz, so it's a Mentimeter. So if you're watching on your phone or something, all you need to do is open the link when I bring it up. I'll go into a bit more about skin, including differences between skin tones, a little bit of history, and then radiation-induced skin reactions, and then how we can improve equity. Just to say, equality, diversity, inclusion, it's a bit of a buzz term, I would say, probably for the last 6 to 8 months. Everyone's talking about how they want to be more inclusive or more diverse or more equal. I stole this from university because it's quite a good infographic. It just explains, very simply what it is. So equality, equal opportunities, and then talks about discrimination, which I'll go into a bit more detail, and then diversity, so valuing differences and recognizing, respecting other people, and then inclusion. So I know it says about university, but as I said, I stole this one, but it's just about feeling valued and feeling at home. So looking at EDI in a bit more detail, I'm sure we know, or hope you know, the protected characteristics. So with the Equality Act from 2010, all of these are protected characteristics. You could have one or more of them. Most people probably have more than one. And this is where you cannot, disqualify people in work or whatever based on these characteristics. So something that's always been there, in healthcare as well, we try and be as inclusive as possible. So when we look at equality, I quite like this image. This is what equality means. So everyone's getting exactly the same thing. So you all want to ride a bike, but everyone's slightly different. So everyone's given the exact same thing to get what they want, which isn't necessarily always equal. You might have seen this image before. So obviously it's two people trying to get apples from a tree, but this is the version of equality. So again, two different people. The tree itself is leaning towards one direction. However, they've both been given the same tools to get what they need. So when you think about this in healthcare, we say healthcare is, for all, one and for all. We don't try and we're not trying to exclude anyone from protected characteristics, but this is probably what we look at for equality. So I'll give you. So just go on the www.mentimeter.com and then just put in this code. And while that's happening, I will just share the screen quickly. What screen can you see? Sorry. Can you see the quiz screen, Alison, Lindsay, or Sarah?
Yes, so you can see the quiz screen, and then the code's just at the top.
Sorry, the code's at the top. So 25789433, and then just start doing the question. You can do more than one answer as well. I forgot to say that. Sorry if you've already put your answers in. I've got 5 of these questions, so take time. I should say as well, there's no right or wrong answer. I'm not trying to catch anyone out, but they all kind of mean something as we move forward. How many do we have on the call? Is it 40? I think that's half of everyone. So quite a provocative question, I know. It is a part of life, I would say. So fine, no one's put that, but don't like it, want to do something about it. Agree. Colorblind, fair enough. I'll leave that as to how it is. So next question. Do you think everyone's skin is the same? Good. I'm glad everyone's saying no. Cool. So halfway. So looking at black skin in particular, do you think black skin is thicker than white skin? Interesting. Okay, a couple more seconds. So mainly no, and I'll go into this in a bit more detail. So do you believe skincare assessment in radiotherapy is prejudiced? Cool. Mainly yes, that's good. Probably wouldn't be speaking here today if it wasn't, I guess. Cool. So the last one. I think it's the last one. How does a radiation-induced skin reaction present on brown and black skin? You can do more than one answer. Also, if there's anyone listening who doesn't know what skin reaction is, don't worry, I will go into that as well. Cool. Perfect. Thank you. I can close that one. So quite a good mix. Nice to know that everyone knows what skin reaction is. I will go into the differences in skin tones as we go on with the talk, so don't worry. So I'm just going to go back to my screen. Can you see my screen okay? Yeah, cool. So obviously the focus is mainly about skin. Most people said that everyone's skin is different. So I'm just going to go through a little bit of the basics around kind of physiology and what skin actually is. As all healthcare practitioners or even people who don't know anything about skin, it's good to know, especially for the depth of a radiation reaction and why. So you might have heard of a radiation reaction, which I'll come on to being called a burn, but hopefully this will kind of explain why we don't normally like to call it a burn. So for me, in anything around skin, it is really good to have the fundamentals. So understanding that, yes, everyone looks different, but the skin itself is actually very similar. So this is an example of someone with probably a white skin tone, but everything underneath is usually the same. So skin itself is the largest organ in the body. So it's about 15% of your body weight. It's loads of different things that it does. So for example, at the moment, it's quite warm where we are in London. So thermoregulation is really good. As a protection barrier as well. So obviously when you get cut, the protection barrier is open and that's when you bleed, etc. You can get an infection. There's three main layers. So the top layer, which is, I think, roughly about 5 millimeters in depth, is the epidermis. This is made up of something called keratinocytes, which I'll come on to and why that's important, but also stem cells. So when you get an injury or something like a radiation-induced skin reaction, that stem cell level drops because that's where the radiation is starting to target first. And that's why you start to see people having a bit of a delayed healing rate from the radiation-induced skin reaction. I might say RISA because radiation-induced skin reaction is a mouthful. And then the dermis, which is slightly lower down. This has a lot of important structures like hair follicles, some blood vessels, sweat glands as well, which is why you'll notice that actually sometimes in this area, once people get a bit, been having radiotherapy for a while, they might have hair loss within that area of treatment because of the skin reaction, but also you might get some damage, some sweat loss as well. And then further down, which doesn't normally get affected by radiation-induced skin reactions or RISA, is the hypodermis, or where the fat layer is. So on the right-hand side, the hand-looking structure, this is something that happens underneath the skin. So it's quite an important aspect. So obviously looking at me and looking at your own skin tone, we all look slightly different. So melanin, the pigment melanin is what gives us what we look like, basically the skin tone. There's two different types. So there's the brown-black hue melanin, which for someone like me with dark hair, dark features, dark eyes, that gives us those features. So people with white skin, they won't have as much of that pigment of melanin, or that aspect of melanin, sorry. There's also the yellow-red hue melanin, which is the pinkish area, so your lips, your nipples, that sort of thing. So yeah, and then looking on the right-hand side, it has, So the yellow lines coming down, if you imagine the top layer where the keratinocytes are, that is the epidermis. So as the sun, for example, just the sun, when it hits the surface, so with rays, it causes more melanin to be produced. So obviously the reaction will be slightly different as to what it shows up on the skin for different people. But melanin is produced by the production called melanogenesis, which I won't bore you too much with. But what it does is it will push from the hand structure on the bottom, the little brown blobs start being pushed up into the keratinocytes, and they'll start to pull closer to the skin surface. And what that does is the yellow, green, moldy, egg-looking structure is called the nucleus. So that's the nucleus which has all the DNA. To avoid any DNA damage in the skin itself, so this is where you can sometimes get skin cancers if that does get damaged. These the melanocytes that transfer the pigment up there, it starts to protect that area. So again, the more you're in the sun without sun protection, the more melanin is produced, and that's how you start to get more of a skin reaction. That's kind of how you tan when you go in the sun for too long, or for whatever. And again, why you should be wearing sun cream 24/7 despite the weather all year round. But I definitely don't. I got burnt recently. So that's it. When we look at skin, so Sarah mentioned in the introduction around Fitzpatrick scale. This is a crude version of the Fitzpatrick scale. It's an image that I really like to use quite a lot because it just shows how it's not really inclusive for everyone. So it's a really good paper by Jyoti Shankar and Stein in 2019. So again, not very recent, it's still quite a while away, but number 1, 2, 3, and 4 is what was initially produced by the Fitzpatrick scale in the 1950s or 60s. And that was used to classify white skin tones only. So either on the left, very fair skin, and then going on to 4, so maybe more my skin tone. And then eventually number 5 and 6 was added on because they realized that people with brown or black skin weren't being included within this. There's no research for this. It was just added on as different skin shades, basically. Whereas number 1 to 4 has had a lot of research within it. And then, 1975, sorry, I clicked on my notes. But yeah, it's an observation-based tool. So looking at someone's skin, they could either self-classify their skin tone or a medical practitioner could do it. There's loads of studies from the 1980s onwards that says actually for brown and black skin, this is not inclusive whatsoever. And there's a lot of myths around it. So you might have heard, the blacker your skin is, or darker your skin is, the less likely you are to get sun damage. So I'm supposed to be number 4. A few weeks ago, I did a triathlon. I didn't put any sun cream on and I got really burned. So yeah, it's a myth. Something a bit interesting, which I like to talk about in this paper as well, is actually the amount of melanin or skin pigmentation that you have in your skin depends on kind of where you originally come from. So closer you are to the equator line, so the longitude and latitude equates to kind of the radiation intensity. So you can usually around the equator, it's a bit higher than, for example, in the Arctic Circle. So people usually on the equator line, they are more likely to have highly pigmented skin, so brown or black. Obviously, it can vary depending on the humidity levels and things like that as well. So if you're looking at like South America, a huge chunk of that is the Amazon, where not many people live in either. And Australia, if you know, they used to have a hole in the ozone. I think it's now fixed somehow and it's back to normal. If you've ever been in the sun, for example, for me, so I was born and raised in India. The main way I get kind of synthesize vitamin D in my body is from the sun rays, but the UVA rays are the ones that would penetrate deeper into the skin. So the closer you are to the equator, the further you move away, it's more UVB. So that's slightly less. So when you look at your sun cream, you'll have UVA, UVB. Ideally, you want both, but for some skin tones, you need it slightly more in different areas. So actually, people with white skin tones, so that number 1, 2, maybe 3 in the Fitzpatrick scale, they're more likely to require less UV to synthesize the vitamin D. But actually, lots of people have vitamin D deficiency because there's not enough sun, there's not enough penetrating deep down. If you ever put sun cream on, which I hope you have, the sun protection factor that comes up on the skin, so the SPF factor, naturally for people with highly pigmented skin, so for example, someone like me or from someone closer to the equator where they were born, they're likely to have an intrinsic, so already in their skin, have an SPF factor of 13.4%, whereas someone further away from the equator, I think it's around 3.4% is the intrinsic factor for someone with white skin. So the protection levels are slightly different for everyone. And this is again where some of that myth around black people having darker skin comes from, but it's not true. And I'll come into even more detail and give you a very relevant history lesson as to why it's really not true. But all that's happening is the melanin production that I showed you from that weird hand structure into the skin. For people who are closer to the equator, they just have more of the pigment melanin that's protecting the skin, so the nucleus under the skin, and that's why people think it's their skin's thicker, but it's not. So history lesson, looking at radiography in particular. I think this is from the 1960s, the 1968. On the right hand side, you can see that they classified skin for normal X-rays. So this is more of diagnostic, superficial level, so like chest X-rays or something like that. So they would always classify the norm. This was from America. So Bavely and Jones in 2022, they looked at this. In America, the norm was an average white person. And then for people with brown or black skin, so exactly as I said, for the myth about black skin being thicker, they would classify people like me, people like my friends who were black, hard to penetrate. And then because of that, so looking on the left-hand side for the general body consideration is for someone negroid, which is a racist term for a black person, they would require you to increase the exposure of radiation up to 40 or 60% more to penetrate deeper because of that myth. So if you imagine everyone on this call goes for a chest X-ray, I might get maybe 30 to 40% higher than someone who has white skin. One of my friends who has black skin might get 60% more exposure just because they thought the skin was a bit thicker. But the other thing is also for body mass, so waist circumference, body mass index, whichever one that you use, 5 to 15 times more for someone who's extremely obese. Again, obese isn't the best term to be using anyway, but also back in the 1960s, I think obese would be anything, I don't know my BMI scales to be honest that well, but it's not what we would imagine it to be now. But again, just wanted to show you the considerations of what things used to happen. So people used to get a lot higher exposures for radiation just for scans based on these myths around skin being thicker. And obviously you can imagine from a radiotherapy perspective, this sometimes used to equate into the simulation scans and stuff as well. So obviously we're here to talk about radiotherapy. So RISA, this is a really good diagram where shows the skin, obviously the lovely radiation lightning bolts at the top. So if you imagine the radiation hits the surface and it will penetrate to a certain depth to where you want to treat the target volume, tumor, whatever it is. So I talked about the dermis and the epidermis layer. We don't talk about the hypodermis, so the fat layer underneath, because it hasn't shown up in research to cause that much damage to that layer. But this is where you start to see the basement membrane looks a bit wobbly, and that's just because it's becoming slightly kind of less tight because of that radiation damage. So radiation damage, lots of different aspects of the skin. So the hair follicles, as I said, the hair might fall out. The sweat glands, you might start to see in the area of people that don't sweat as much, things like that. And then obviously the melanin production from the melanocytes, so the brown blobs moving up. This is the exact same thing as tanning, so being in the sun for too long. But people with white skin, you'll start to see that it goes a bit redder or pinker first. People like me might be like maroon, maybe a kind of black kind of look. And then obviously people really dark skin, you don't really normally see redness. I know we talked about that in the Mentimeter quiz. But yeah, so as radiation hits the surface, usually I think we're taught that actually a reaction shouldn't happen in the first few days. There's evidence that says that you can get a radiation reaction after 2 hours of the first radiation dose. Very different to what I was taught at university. And usually inflammation where those stem cells in the epidermis layer that are damaged, that can actually happen within probably the first 24 hours that you start to see inflammation. So we'll give you a real life example. So breast patients who are having the accelerated 5 appointments a week, there is a lot of evidence that actually they're getting quite a harsh skin reaction from day one, and then it gets better. But then they have a delayed response, and there might be 2 weeks, 3 weeks later that they're starting to see more of a skin reaction. There's not enough research about this. So if there's anyone listening and you want to look into it, please do, because I think it's quite necessary and needed. But yeah, that's radiotherapy. So in healthcare, I don't know if there are any patients listening, but if there are, within healthcare, we like to make things easier for ourselves, and we have lots of different fancy assessment tools. So in radiotherapy, there's 2 main ones that are used across the world. Radiation Therapy Oncology Group, RTOG, or a very long one, I'm going to read it, Common Terminology Criteria for Adverse Events, CTCAE. They are slightly different, and in America, CTCAE is more common. I think in Europe, it's a mixture. In the UK, so I led a survey a couple of years ago, and I think over 45% of therapeutic radiographers in the UK use RTOG. However, they talk about the skin reaction, so 1 or 2, so 0 should be no changes. But again, something to point out is no changes can be different for lots of people, just to make sure we have a baseline. So one is where you might start to see a little bit of a skin reaction. And we talk about this word erythema, which I'll come into in a bit more detail. Erythema means redness. And actually lots of simplified versions of both of these tools say redness. And actually I won't talk about this, I'm kind of saying in one of my next slides. Just wanted to highlight that the terminology, this terminology hasn't changed since I think our TOG was produced in 1995. It's the exact same terminology since then. It might have adapted in other aspects, though, for diarrhea or other aspects the tools used for different side effects across the body, but it hasn't really changed. So I think, so now when we start to consider, how different we all are for our skin tones, how ultraviolet radiation starts that process of melanogenesis and melanin on the skin, and then also how Fitzpatrick scale has been the basis of a lot of tools for skin in dermatology and like this for radiotherapy. You can probably start to see that things aren't really that inclusive or equal, so equality, exactly as I talked about in one of my first slides. And actually the language here isn't that inclusive of all skin tones. So didn't talk about it, but I will now. So consent forms. These are the Royal College of Radiologists. I know it's quite a busy slide, but the Royal College of Radiologists I think last year, January, they came out with these fantastic standardized consent forms for radiotherapy. So these are just the bits about the side effects and what commonly happens. However, again, they all say redness. So from 2023 to 2022, we've been consenting patients for all these different sites who will be black and brown, but for saying redness. That's incorrect clinical information. We're doing it since 2021. It's been going on for a while, and I have helped them kind of, redo these bits for different terminology. So I'm still waiting for it to be out, but it's been over a year now. So if you think, I work in Northwest London at the moment, and lots of patients we see have brown or black skin. Probably every other week, you'll get 2 or 3 different patients saying, well, I've been consented for redness, but I know that's not true. My skin never goes red. So again, we're looking at the tools from right from the beginning. They're not inclusive for everyone. So again, looking at that tree scaling towards one side, yes, we're giving everyone the right tools, but the tree is still leaning towards one side. That's white skin for exactly this. So I think it's just something I wanted to point out. Hopefully it will start to change soon, but it's something just to consider that if you are consenting patients or you're explaining in a first aid chat or in side effects management, or if you're going for treatment, there are key differences, and it's really important to just challenge your healthcare practitioners who are talking to you about the side effects. So talked about erythema. This is a screenshot from I think it's Wounds UK, so I'll put a link on the bottom if you want to go on it now. So this is 2021, and actually what they had in Greek, we know I don't know the language, but erythema actually comes from the Greek word erythos, which means red. So again, for someone with black skin saying they have erythema, it might be physiologically correct underneath the skin, which I pointed out, but on the surface it isn't. And the main thing that erythema is increased blood flow. So yes, I know blood is red, but on the outside of the skin it does look different. So I talk about the misconception. So with the Fitzpatrick scale, I'm a number 4. I shouldn't burn apparently, but I do burn. It's not very comfortable, and it's quite embarrassing, seeing as I talk about skin quite a lot, but it happened. The term redness itself is actually very misleading, exactly as they said, because there's a whole spectrum of colours that we're not talking about. Actually, when we talk to patients with white skin with radiotherapy for a reaction, we will say it might go pink or red. But for when it comes to someone with brown or black skin, actually it might just be subtle darkening. But also for people with white skin, they might not get any redness at all, and then it would just look like a tan. It's very varied, but we're still using that one size fits all to explain things. And actually so Wounds UK, and this is this is taken from the British Association of Dermatology. Again, 2021, very, very recent. This is a difference that people with brown and black skin have known for centuries, but it's only now come out in evidence that there isn't a straightforward way to predict erythema on the skin. So it's either subtle darkening for brown and black skin, it could be maroon, it could be purple, yellow. I have a friend who has very pigmented skin, and she always says whenever she gets checked up for her eczema, it usually looks grey, and the GP never knows what to look for to understand why her skin is grey and keeps telling her to just wear normal moisturising cream. Actually, it's just a change in the colour of the spectrum for something like this that's happening underneath the skin. So radiotherapy tattoos, just wanted to touch on really quickly. On the bottom left, obviously we say the tattoo is less than a 5p coin, blah, 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 but this is on white skin, and it's what is it? I think it's actually called Indian-ish. So it's very dark navy or black color. And that's what it looks like on a white skin tone. On the right, I don't know if you don't have to mute, but I'll give you like 5-10 seconds to tell me where the tattoo is. So the exact same ink that we use, same technique, nothing's different from the person on the left. It's quite hard, I'm hoping you're saying. If you found it, great, but that's where it is. It's quite hard to see. And again, if you've ever worked with someone with black skin as a patient, how many radiographers have got their torches on, put all the lights on, and are crowding around in that patient's personal space, very undignified. It's pretty horrible. I've never enjoyed it. And it's just not nice, but this is just something else that's kind of cropped. I mean, it should have cropped up a long time ago, but it's cropped up now. So Saran Wickers is a consultant breast therapeutic radiographer at UCLH. She is leading a trial called the NEAT trial. I can't remember what the NEAT stands for, but if you want, I can email it to people afterwards. But just wanted to highlight that she is looking into this, that different shades of ink that might be better suited for black skin, brown skin, stuff like that. So there is something being done about it. There is obviously also surface guided radiotherapy, quite an expensive thing for departments to purchase first time round, but it is great. However, there is some anecdotal evidence that again on brown and black skin, it doesn't necessarily map the skin as well. I got a message on LinkedIn from someone who's a medical physicist who was in India. There's someone doing a PhD looking specifically at this issue, so around the mapping. And not to throw any more curveballs at you, but if you think about artificial intelligence, lots of these things, if you look at the main kind of structures of what medical information we put in, so medical imagery, etc., it's usually of white skin. But I think from talking to Vision RT, who 5 minutes here to switch it off. Can I mute? So looking at equality, this is what we talked about for equality. So what I said, so the system, everyone gets the same thing. So the person bottom is getting the same ladder to get what they need. However, this is what I would like to look at. So equity is probably a term that people have, I'm hoping, heard as well. So everyone's got the same issue. They want to ride a bike, but we give them all different types of bike.
Let's be finished in a second, then we can sit more.
Sorry, who can you all mute your sound, please? But yeah, looking on the bottom for the tree. So the tree is still leaning to one side. However, the person on the right has been given tools to be able to get what they need effectively. However, if you still look at the tree a bit closer, there's still not enough force for that person on the right hand side because the tree is leaning towards one side. So something I just want to talk again. So 2015, this paper I think is this is a different way to look at skin shades or skin tones. So instead of the 6 Fitzpatrick scale levels, this is something that Ho and Robinson looked at, and I think this has been validated and used in research as well. But another thing to add on to this, so last year Wounds International did an international consensus around what terminology to use for different skin shades. So something I talked about this at Estro this year, holding my hands up, I've always called my skin looking darker than someone else's, but actually again saying darker is implying that that white skin is still the norm, as opposed to being, just my own skin tone is my own skin tone. So what they have suggested, I would probably say to you as well, is just to say white, brown, or black. And this has been split up. I've split this up, into these different shades. So the white is probably more at the top, and then it's looking brown is a bit more. Black is obviously a bit more pigmented towards the bottom. It's just to try and change the terminology, but also you can just ask the patient what they would prefer. I think making assumptions, if you're not sure or feeling sensitive and I'm not actually saying anything, that's probably worse for patients in my experience. And for example, like using terms like BAME, absolutely hate the term BAME because it just puts everyone in the box really, because there's lots of different Asian aspects. But it's so using like person of color or just asking the person in front of you what they would like to be called, which might just be their name. I know feet are gross, but it's just an example of how we should be doing a baseline. We don't normally treat feet, but this is someone's normal skin tone. So actually across their body, they might have hypopigmented skin like this. So this is someone with brown, black skin, but knowing that norm for the patient is really important when it comes to a skin reaction. So if we know that this is what they were like before they came in, and then if there's more pigmentation or less pigmentation that can happen, then again, we can monitor it going through. I don't think we use medical photography enough. I'm pretty sure every pre-treatment team has a camera somewhere if you can find the USB to upload the image, but it's really important to get this baseline. And actually most patients will be quite happy to do it because you're monitoring it day in, day out. I know it's quite difficult to do it weekly, but if that's possible, that would really help the patient. Because then again, when it comes to late effects further down the line, in 6 months, 10 years, or whatever, you'll still know what the skin looked like before. So an example of this is for head and neck cancer patients. So I had a lady who had head and neck cancer last year. She finished treatment 5-6 years ago, and she has brown skin like mine, but she doesn't go out anymore. She only goes out maybe once a month if she can, but hides her face because she now has hypopigmentation from radiation. But that, unfortunately, the GP didn't know what that was. The radiation, the team that she was with, they didn't know what it was. No one knew what her face looked like at the start. So she has struggled for months and months and months, not knowing because no one's done the baseline assessment of it. And the Society of Radiographers, the guidance does say we need to do a baseline assessment. So that is like this, looking at someone's skin in the area. Do they have eczema, psoriasis? That's going to get worse, something like that. It doesn't take too long. I try and do it, and I think it's really important. Going a bit further down the bullet points, so sun damage as well, or even if someone's had a burn in the past in the area, it can mean that the skin within the region of treatment is going to be more susceptible to sun damage or skin damage. Skin bleaching is a common, very strange process that happens. It happens in India, lots of different countries where, again, people want fairer skin. If you haven't been to India, lots of the products will talk about how you can make your skin fairer. And I remember my grandma before, I think when she wanted to get me an arranged marriage, saying that, well, you're very fair, you'll be able to get whatever you want. It's a normal practice, but it's good to know because actually if someone is bleaching their skin and you're about to give that area radiation therapy and you can see that stark different, they're going to get a very bad skin reaction. And it's something that I've seen in practice. Middle Eastern population people also do this quite often, but it's just something to consider, just to take away with you. Alternative medicines, there's a lot of different things, obviously, but depends on, I'm going to link it to the normal skincare regime as well. So for some people, for example, from the Mediterranean area, their creams that they use normally for their skin, all of their body might have olive oil in because of how oily or not oily their skin is. But again, for radiotherapy, we need to know this so that we can monitor it going through. And that's kind of where some of the cultural differences will start to come in. Another thing to throw at you, if I haven't overwhelmed you already, is people who cover their skin normally for religious purposes. We don't necessarily know, I mean, I don't necessarily get to do skin checks on people from that background, very rarely, but actually sometimes they can have very bad skin reactions because their skin hasn't been out exposed for that often, but it's just something really to consider. When it comes to African skin particularly as well, again, we talked about how people with black skin, their skin isn't actually thicker, but there is some evidence to say that they have more oil glands under their skin, and actually their hair, the hair glands in the dermis layer tend to be a bit thicker. So that can cause some people with black skin to have quite oily skin, and this can obviously have a bit of an issue when it comes to skin protection. So if their skin's too oily or it's too dry, it's just something to consider and monitor. But again, that's where the baseline assessment is really important, asking the patients in front of you. So I've stolen this from the Wound International, but it's a really good, succinct way to, like, action points to take away about assessment. So talks about baseline assessment. This tool was, this thing that I've stolen is mainly for dermatology, but it works for us 100%, I would say. Exactly, so don't look for redness, but for skin changes. All patients will know their skin better than we do. And actually using the different senses, if you've ever been in the sun recently for too long, you'll know the area that's been impacted by the sun the most because it feels really hot. That's normal. That's how inflammation works. That's our body doing what it needs to do. But for a skin reaction, I'm not asking you in an NHS department to try and get an infrared thermometer, but if you've ever seen any research online looking at it, you can really see the rays coming off an area that's had a radiation reaction, or it's like radiation therapy or whatever. So just touching people's skin is really important when you're looking at skin reaction, And also you need to remember that when patients leave us, they've still got another 12 to 18 hours till they come back to us for treatment. Things might change for them overnight, and actually asking patients to record, monitor their skin I think it's perfectly fine. When breast care nurses were struggling to look at wound healing during COVID, they set up their own NHS.net, line just for images to come through securely, and then they put it on the hospital system. So we can do it as well in radiotherapy. It's not an issue if you get your patient to email their skin reaction that they've noticed overnight and put it on ARIA, Mosaic, or whatever we use. I think it's really important because patients like to be heard and listen, and you're empowering them to do what they need to do as well. So if you're eating, don't eat. I've got a couple of skin reaction photos just to show you the difference between redness and pigmentation. So on the right-hand side is the clear definition of erythema on someone with white skin. You can see the very clear defined radiotherapy edges, which if you're a therapeutic radiographer or dosimetrist, we're very, very proud of because that's our millimeter accuracy working really well, MLC, etc. We know what we're doing. But that's redness, that's erythema. On the left, obviously where you're looking just underneath the breast for this lady, that's the inframammary fold where we normally do see some friction or a bit of a skin reaction. So that redness is actually the skin layer underneath. If you've ever grazed a part of your body, that's what's happened. But the rest of it, I mean, please correct me if you think I'm wrong, but I can't see any redness. So I don't see how an RTOG or CTCAE scale would work for something like this. And that's why I'm here shouting about it. But this is the very, very obvious difference. And you can see how much, darker or pigmented this lady's skin is compared to her abdomen or her contralateral, her opposite breast. That's a skin reaction. That's how much it can really look like. And actually, for someone like this, they will probably be in a lot of pain, and you'll be able to touch their skin if they let you and consent, etc. But you'll be able to feel and know exactly how much warmer it is compared to their abdomen or the other breast. So hopefully, visually, this kind of shows you quite nicely how it's very different. So this is what I want. So fixing the system. So the tree is no longer bent. There's apples everywhere. Everyone's got what they need to get what they want. This is justice. So you talked about equality, equity, inclusion, diversity, blah, 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 all of the terms, but this is what we should be going for. So if the tree is the lack of representation in medical imagery or tools and assessment things that just don't work for all skin tones, this is what we have to do to fix it, is fix that system, give everyone what they need. So it's still equality, equity, diversity, inclusion, everything in one. So I'm just going to go through something that I've been working on in my own time, but for using the Hohen Robertson skin shade, so that I'll just quickly run through. So got all of them, but I'm just trying to get this validated. Hopefully Radiotherapy UK will help, and an industry partner as well. But looking at the different kind of amount of grey, so radiation, the amount of radiation that we give, so early, moderate, early, moderate, blah, blah, blah. But this is for the white skin tones that I showed on the Hohen Robertson scale. So you might get faint redness, faint pinkness, which will develop into either hyperpigmentation, which just means the skin's darker, or it might be red. But then also to talk about how the skin would feel. So where I talked about the basement layer in the skin becoming slightly damaged and the stem cells causing inflammation, the lack of stem cells causing inflammation, that's where the skin might feel a bit harder, a bit tighter. And then obviously the warmth, which I've just kind of explained with the patient before as well. Just something to consider. I think it's really important that we start to use the right terminology and hopefully vary it for different skin shades. So for someone like my skin tone, depending on how much I've tanned in the summer, I guess, out of the three here, but you might sometimes see a bit of redness on me. It's not very often, but actually maroon is probably a better term to use. And again, hyperpigmentation, so it just looks darker. I tan very quickly, so I might be in the sun for one day, even with sun cream, and I will look like I've been on a holiday for like 2 or 3 months. But it can be that quick for some people. And actually, for people with brown skin, you might even notice that their skin reaction, their skin starts to look darker within a couple of days. But that's again that melanin process, the production of it, it's just working quicker. But you can see it quite nicely. And then for brown, so probably dark brown, black skin, there's different color spectrums that we need to think about. So sometimes you can go yellow, sometimes you can go purple. You can also look gray, as I said, with my friend who's got eczema. You can also start to see a bit of maroon color, but this is where the sensors are really important. So touching the area or asking the patient if they've noticed, you'll definitely know that it's harder, it's tighter, but the warmth is really important. And actually this crosses over into so Wounds UK, some of the info that I've stolen from, but they, this is what they talk about. So where the for diabetic foot ulcers, for example, you're never going to see redness, but they've started to use the sensors more, and they're finding that actually people with black skin who've had diabetic ulcers, they've been missed a lot for decades, basically, and they probably could have had their toes kept and things like that. But it's because of using tools that aren't inclusive for everyone. So just going to highlight it again. Hopefully that's my way of trying to fix the system. I'm sure if you've heard me shout about it, it does infuriate me that we're still in 2023 not inclusive of all skin tones, but hopefully we'll start to get there and things will start to improve. So yeah, in summary, I've stolen this again. It's quite nice when other people are doing some really good things too, but simple language. I know I use the term hyperpigmentation, but saying brown, black, yellow, whatever it is. Some people know what pigmented means, some people don't. It's a term that I quite like to use when it comes to a professional level, but for patients, you need to alter your terminology a little bit. When we start to think of different patients from different backgrounds where English might not be their first language, using the caregiver or interpreters to make sure you do understand a good baseline of their skin, tell them what's going to happen, and hopefully now I've given you the tools to say if someone has brown or black skin, it's not just going to be redness, there's other things to look out for. Yeah, making sure everyone understands. So this will obviously cross over for pediatric patients, teenage young adults as well. It's for all skin tones. To give an example, there was a health visitor. We did a podcast about this a while ago on RadChat, and they did the CPD stuff and reached out and said, actually, knowing the difference between redness, brown, black skin, everything, it's helped her as a health visitor with children. I think even maybe this is just me trying to get deeper from the surface, but there's tools in physiotherapy that still say redness. It kind of crosses over everywhere, but it's just really important, hopefully, with the tools I'm trying to show, that we can't keep putting patients in boxes exactly as it says here. Also, you can just ask the patient what they like to be called and what they want for their skin, what's normal for them. If they've ever had a sun reaction, like sun damage or whatever, then they can tell you what it normally feels like because it's similar to radiotherapy. But yeah, references. Thank you. It's my email and Twitter. If you want to chat, disagree, agree, anything. The link on the bottom for the Just Giving, I stupidly signed up for a full distance Ironman. I'm raising money for Radiotherapy UK. If you fancy giving me some money out of pity, I'd really appreciate it. I've got less than 2 months to go till I do it. But yeah, thank you very much. I'll stop sharing.
Thank you so much, Naman. That was really, really fascinating and really thought-provoking, and also lots of practical, advice and tools that people can take away and implement in their departments. And we've had lots of questions and lots of engagement and comments through the chat. So if we'll just crack on with that now, and if I can pass over to Lindsay, I'll let Lindsay put forward the first set of questions.
Yeah, just a couple of things really that you might be interested in, Naman. But Eloise, the lead review radiographer in Cheltenham, said that she's got a colleague doing an MSc dissertation looking at the skin reaction of 5-fraction breasts. So that's amazing to hear. Something that hopefully we'll see some results and hopefully see what they come out like. On the back of that, actually, Diana said that she agrees with you in terms of seeing a very early quick reaction and then things settling down, and then seeing much later reactions in those 5-fraction breasts of sort of 4 weeks and longer later. So that's kind of clarifying some of the things that you're saying, that obviously people are seeing similar things. So
it's
that's
something
really
that we
good
started to pick up, I think, a year ago. We started to pick that up. There's a few patients that I've worked with, and with brown or black skin, they've noticed that they got skin reaction way past the 14 days that 10 to 14 days that we suggest that the reaction will peak. But again, unfortunately, because of that, they were in the grey area where people weren't sure if it was a skin reaction from radiation or something else. But yeah, it's good to know people are looking into it because it is really, really important.
Yeah, amazing. Another comment from Diane was that they use SGRT on all of their patients, and that it seems to work quite well for really all skin tones. So they don't use tattoos at all anymore. So that's an interesting point. That
yeah, brilliant.
that kind looks like it's more the future of where we want to move into, tattoo-less treatment and using tools like SGRT. So that's quite a positive affirmation that is a good way forward for all.
It is for the UK. I completely agree. But if you think of Africa, it's not going to happen. And actually, what they do is they copy everything the Western world does. So if you friends and colleagues who I know who are radiation therapists in India, I asked them for their skin protocols, and they just said they just use redness or whatever. But now they're starting to change it because they've just copied what we do, and that's the same in Africa, where places might only have one linear accelerator. They're very unlikely to get surface guided. So I think it's great, but we need to do more work in this area at the same time. Same with like tattoos. There's lots of different things that are coming out, which I think are less permanent than the options we have. So yeah, things are definitely changing. Obviously, I'd like them to be a bit quicker.
And that's interesting because Pat, Professor Price is also talking about this would be really good internationally as international guidance, and that might be something we try and tie in with the GCR and their work with standards within cancer plans for radiotherapy, because it's so important. And as you say, if the lead is being taken from the UK and other European countries, then we want it to be right for patients, here and globally. And I suppose one of the things off the back of that is Tim was asking, kind of saying this would be really good, valuable work with the College of Radiographers, and just wondering kind of what work you've been doing with them and how the implementation of this out through departments and through that as a platform.
Yeah. So I led a survey. It's almost been 2 years. I'm still finishing writing it up with so Dr. Rachel Harris and Prof. Heidi Price and Corinne, who works at the Society. So from that, a lot of this evidence has started to come out that actually across the UK, I think the difference was when we compared confidence levels between so let's say everyone on here who's a therapeutic radiographer, how we would assess a skin reaction on a white skin tone as opposed to brown and black. People were 72% confident looking at white skin tone, but only 46 for black. So for black or brown skin tones. So that's, again, to get anywhere in research, you need that grounding kind of evidence from the beginning. So now having that, working with the ESTRO, so European, let me get this right, Society of Radiotherapy and Oncology. So part of their new skincare guidelines that are coming out, and one of like Heather Nisbet as well, one of the society members who are working with that. So there is a lot of crossover. But obviously the 2020 guidance that came out by the Society of Radiographers was already really good gold standard. On the patient leaflets as well, it does say your skin will either go redder or darker. But they already had that terminology in there, which is really good to see. So yeah, I think SORs, I'm always going to be biased because I'm working with them for this sort of stuff. But there's a lot of things. I think webinars like this is the next thing on my very long to-do list to do with them, hopefully at some point this year.
Great. And I suppose there's just a few things coming through then, almost off the back about that, but how that actually becomes embedded within learning and teaching, to become like best practice within the departments. There's one there about how, what would you be recommendations on how you actually sponsor inclusiveness in radiotherapy skin language as an individual or radiographer within your collective department?
I mean, things like the consent forms. Not everywhere uses the RCR, so the Royal College of Radiologists consent forms. It might just be good to have a look at your own and see what that says there in the side effects. That's probably a good start, because if it still says redness, it's unethical to be consenting brown or black patients with something that says redness because it's not true. So that, from a governance perspective, that's a good place to start. I think most places will have a internal skincare protocol. I think I saw Poppy was in, who talked to you about this as well, but just changing the terminology. While there isn't anything specifically for radiotherapy yet, I'm working on it, but the stuff that I've used, like Wounds UK, Wounds International, their terminology is all based from dermatology, but it's the same thing, it's skin. So if you can start to reference those until all of like the different works that are starting to come out, hopefully this year and next year, then starting to evidence it, you'll start to cross over. I think, to be honest, now that you have the power and you know the difference, in a way, it's kind of your responsibility to help your departments as well. I'm not trying to put it back on you, but it can't just be people like me always shouting about it at webinars. If you've got the information, we need to do it. speak to your different patient support groups as well. There'll be PPI groups from the research, like the research groups within the hospital, speak to them, or if there's a radiotherapy evening, stuff like that. Yeah, can't just be people like me and all the other people in the Astro Skincare Guidelines. Everyone else, now you've got this knowledge, you need to start pushing in your own departments a bit too. And the society, I'm working with them to obviously do webinars and things to make it wider as well. And then through Macmillan as well, which is quite nice because that's UK based, so Northern Ireland, Scotland, Wales, doing it from that angle. I'm also working with Trinity College Dublin University to update terminology. So the Irish Cancer Society have updated their terminology of a patient, so for the whole of Ireland. So that's a great start. But yeah, stuff like that. Like if I can reach out to these people and just ask them to change it, if you see something, you can call it out too. That's what I would say. Bit of a challenge to everyone else.
That's I mean it's so true. Everybody has to be involved in this and take it forward and take elements of responsibility. So that's really, really strong. And you're so busy. Naman, I don't know how you managed to fit everything in. But Lindsay, was there anything else coming through there that question wise?
Sorry, I was on mute. Yeah, there's one question here saying you showed an example of query and RCR consent citing erythema. What consent was it? What site? Sorry, I didn't get that at the beginning.
Oh, sorry, I should have said. So that was for, I did the 4 main sites that usually get more of a skin reaction. So breast, head, neck, gynae, and I think lower GI, are those ones. I'm pretty sure, I mean, I can't forget the lady's name, RCR, but they should all be updated because I've updated the terminology with them hopefully this month or next month. So they should start to come through. If you go on the Royal College of Radiologists website for the consent forms, I've written a blurb there which highlights the differences in skin tones anyway. So the information is kind of there in the interim. But yeah, on all the skin, even for late effects, actually, it still came up as redness as well on the RCR consent form. So those are the 4 main sites that I put on the slides.
Okay, just aware of the time here. So again, there's really strong comments coming through about the idea of asking patients to email through the photos, and even having the discussion on the phone doesn't actually give you an idea of what they're talking about, and actually being able to have that visual aid is so useful. And I think it also, from the perspective of patients, it's really helpful to know that that's something they can do, to make them feel more involved in their care as well.
Yeah.
And following on from that, just about the patient side, then just wondering, I know you have been working with patients in this, but what kind of feedback are you getting from patients about this and their engagement with it?
I think the engagement has been really good. Skin reactions, I think as healthcare practitioners, we might not understand psychologically how much of an impact they can have on people. I had a patient who couldn't go to her daughter's wedding because she couldn't put her wedding outfit on because the skin reaction in the breast area was that sore. But that's the impact they can have on our patients if they're having 5 appointments or 6 weeks worth of treatment. So just understanding that to begin with is, I don't know, it's just sad, to be honest. So it's 2023, I keep saying it. I don't think we talk to our patients enough about the psychological aspects of things. And again, if you talk to a brown or black patient and you say to them, I'm really sorry that you signed a consent form which isn't actually inclusive for your skin tone, there's a lot of anger there. And this crosses over into prostheses as well. So I had a patient a couple of years ago, very lovely lady who had very black skin. And when I went to do her chest examination just to check the skin reaction, her prosthesis was white, but that's all she was given, and that was only a year and a half ago. But that's the level that if you start to speak to your patients about stuff like this, it goes really deep. And actually, we're very, very, very far behind making sure that everyone has access to what they need. So there is some work with the Royal Marsden and Black Women Rising looking at different shades of breast prostheses now. But again, that's still 2023. We're still very far behind. But overall, I think from a skincare angle, there isn't a lot of patient-reported outcomes. So we might ask a patient how their skin is, but we rely on our own. So exactly as I said, that we rely on how we look at it, how we assess it. But the patient will know if their skin reactions got worse overnight. So I think, yeah, we need to ask them a bit more. That's usually the feedback I get when I speak to patients.
And we're looking forward to supporting you on that patient engagement piece and being able to move forward with that. So it's really, really important work. So thank you so much. So thank you so much, and Naman, what a fascinating presentation. Just before everybody goes off for the rest of the evening, I'd just like to take a few minutes just to share some updates from our end. You'll see in the chat that we're asking you to share just one takeaway from tonight. Please do let us know what this is, as it's really, really useful feedback for us. We'd also like to, sorry, that's me going too far ahead here. Okay, apologies. Here we go. Oh, I'll let Lindsay look after that.
I'll take it back.
Thank you, Lindsay. I'll let you look after that. So yeah, we just want to draw your attention to our recent international comparisons report on radiotherapy services. So that's on our website now, and really worth a look if you want to understand the campaigning element of what we do at Radiotherapy UK. We were down in Westminster last week to launch that report, and we spoke to some MPs from across the party spectrum who really care deeply about this issue. So please do know that we're working our socks off here to try and help you to get the equipment and the staffing that you need to continue your work, saving and changing lives. And we're also really excited to say that we're making some really great headway with our patient resources project. If you took part in Miles for Radiotherapy last year, then your fundraising is helping us make this happen. The first session of our patient engagement group has met, and they'll be inputting heavily again into the resources we're creating. And the next RT UK Talks webinar will be with Luca Cosi from Varian on September 27th, so after the summer break. And it's going to be called Adopting Adaptive Concepts, Workflows, Initial Experience of Advanced Cone Beam CT Technologies. And finally, I'm delighted to say that we have more than 200 fundraisers and participants that have signed up for this year's Miles for Radiotherapy Summer Challenge. So registration stays open throughout the entirety of the event, and it starts on the 1st of July. It's £20 to enter, and it's a really important fundraiser for the charity. We're a small team, and we're really reliant on fundraisers like this to enable us to do the work that we do. And if you did find this evening's talk valuable and you want to give back, signing up is a really good way to do that. There'll be a link in the chat which will take you through to that information. So thank you all so much for the engagement in the chat. And thank you, Naman, for just a really fascinating, inspiring and challenging talk. It's been great to have everybody here with us tonight. And I hope you all enjoy the rest of your evening. Thank you.